Corey. Okay, let the record show that I just thanked the Zoom committee, but I won't go through and do it again. And another shout out, as some of you who've been on for a couple of minutes, to John Huffnagel up in Owl's Head, Maine. Johnny had open heart surgery last Wednesday, so he's 8 days out. And we're not going to make him laugh. That Ron Boneson, that means you. So we're going to try to stay serious tonight. But Huff, it's great to see you and Annie and Jinx and Casey and all the family that you've got up there in Owl's Head. So it's wonderful to see you. Okay, let's begin. We've got a real treat tonight. We've got Andy Binder, and I'm going to read the bio. It's the same bio that's been on the website, so please excuse if you've read it recently. But it's so fascinating that that I think it's worth a view. Let me put it on speaker view here. Okay. Let's see. So. After graduating from Williams as an English major and pre-med, Andy went to Harvard Medical School, where he says, "I planted myself firmly in the back row." In his second year, lacking an affordable car, he bought a non-running 1959 Porsche 356A Coupe for $425 and rebuilt the engine. He also wrote music and played guitar in a jazz band for the second year show. Despite these distractions, he managed to secure an internal medicine residency slot at the University of Washington in Seattle. He loved the program and Seattle, but even more importantly, during his second year there, met a young woman named Carolyn Green. They've been married now for over 50 years and have two daughters, Alexis and Adrienne, and two granddaughters, Marin and Samantha. After completing his residency, Andy was a general medical officer at the U.S. Public Health Service Hospital in Seattle. He and Carolyn then moved to San Francisco, where he did his clinical and research fellowship in pulmonary medicine at UC San Francisco, UCSF, and the Cardiovascular Research Institute. In 1978, he abandoned his initial career plan to be an academic and went into private practice. His first practice was at Alta Bates Hospital in Berkeley, but a clinic in Santa Barbara made him an offer he could not refuse. He was the ICU director of Cottage Hospital and subsequently formed a 3-doctor private pulmonary group. In 1994, he went solo, practicing pulmonary critical care and sleep medicine. He founded the first sleep center in Santa Barbara, and it was the 17th accredited sleep center in the country. After selling his sleep center and practice in Santa Barbara, he went to work with a bariatric weight loss surgeon in Ventura nearby and established another sleep center where he continues to practice today. He and Carolyn still live in Santa Barbara. His career interests have been in the pathophysiology of pulmonary edema, exercise physiology and exercise testing, and sleep medicine. He has 2 patents related to cardiopulmonary exercise testing. Besides his family, he's most proud of having learned to surf at the age of 43 and becoming an instrument-rated pilot at the age of 70. He's pretty sure that, as he says, had I grown up in Santa Barbara and learned to surf as a kid, I would not have finished high school, much less gotten into Williams. So it's with great pleasure that we welcome Dr. Andrew Binder. Andy, over to you.
Well, thank you. I can't tell you how much fun it is to see familiar faces, not so familiar sometimes, but certainly the familiar names. And I really feel honored to be able to have the opportunity to give this talk. I want to introduce my older brother, Robert Binder, who was he was the class of 1963 at Williams. And in many ways, he was kind of a mentor and role model to me. So I'm glad he happens to be visiting with his wife. And so Bob, Deborah, his wife, and my wife, Carolyn, are watching. So I thought I wanted to start off with how I became a sleep doctor. It's a story, and it really is relevant to actually why I'm giving the talk I'm giving tonight. When I came to Santa Barbara in 1980, sleep apnea, the term actually was just replacing the initial term for sleep apnea, which was Pickwickian syndrome, because all the patients that we saw with sleep apnea early on were obese men and who were in respiratory failure, and it came from the Charles Dickens pictures in one of his book engravings, which showed a fat boy sitting in the corner sound asleep. But we soon learned that you can be skinny and have sleep apnea as well. So I became interested in sleep disorders as early 80s started, and I started giving lectures on it, often greeted by blank stares and from my medical colleagues. And I decided that I couldn't study these people. I had no way of evaluating them. And I couldn't convince my hospital couldn't convince the hospital to us build a sleep lab. And I couldn't convince any of my neurology colleagues, one of whom actually was trained at Stanford. So he knew something about sleep, probably knew more about sleep than I did at that point. And he didn't want to do it. So I said, oh, hell, I'll do it myself. I figured if I could figure out how to rebuild a car, I could figure out how to put together a sleep lab. So in the mid 80s, I thought it was a good idea to drive up to Palo Alto for a 3-day course on sleep apnea. And it was a good idea to drive. I had been on call the weekend before. I worked all week, and I started my drive after making rounds at the hospital. So it was already evening, and I'm kind of a morning lark. By rights, I should have killed myself. I was so sleepy. I was going off the road and so forth. I was nodding off the wheel, and it's only by the grace of God that I survived. And I staggered into the classroom the next morning, and the first talk was given by a guy named William Dement, who was the founder of the Stanford Sleep Clinic and really single-handedly brought sleep out of the research lab into clinical medicine. He didn't talk about sleep apnea. His talk was about sleepiness and the dangers and consequences of being sleepy, all the disasters, the Exxon Valdez, the Challenger disaster, all caused by people making decisions when they were sleep deprived. And I said to myself, oh my God, he's talking about me. And I said, I remember the course, but I remember that 30 minutes like it was yesterday. As I drove home, and I said to my then one of my medical partners, who was, I said, George, I said, we are missing this. I'm going to become a sleep doctor. So that's the way I started. After I read, there were 2 textbooks. I read them cover to cover. I went to Alabama, where there was a sleep institute, one of the early ones, and I took a week-long course. I traveled to various parts of Oregon, and I learned how to hook people up, from the technicians. I learned how to hook them up for the sleep test. I learned how to, glue these electrodes onto their scalps. I bought an EEG machine, which is essentially a polygraph machine, built an amplifier, hooked an oximeter to it, and bought an atlas and taught myself how to read EEGs so I could score the sleep. And finally, I documented everything I'd done, and I couldn't take a fellowship, so I petitioned the American Board of Sleep Medicine, which is a fairly new board at the time, and I petitioned them to allow me to sit for the exam. It was a 2-part exam. I passed the first part. The second part, I had to fly to Ohio and Columbus, Ohio, being sleep deprived again because of the jet lag, and sit where we had a practice. We literally had stacks of fanfold paper from the EEG machine, and I would have to turn the pages and they'd ask questions. And about 10 years later, I was actually invited to be on the panel that scored that board, because that was hand scored. So it's been quite a ride. I actually slept in my office. I hooked up one patient at a time, having converted our pulmonary function lab and made it look like a living room. Drilled holes through the wall, and I initially hooked the patients up myself and monitored them, and I'd bring the paper home and I'd score it and tabulate it, because there was no software then, no computers, of course. And then I hoodwinked 2 UC Santa Barbara pre-med students to help me out, and they'd come and they'd work at the lab, and I would sleep on an air mattress in the office, and then start over. Finally, I moved over to the hospital, hired some help, and the rest is history. So it's been it's through this whole experience, I realized that there are two little sayings that we have in the when you're taking flight training. One is that, and this applies to being a doctor or any profession or anything really. It says it's good to learn from your mistakes, but it's better to learn from somebody else's. That's the first one. And the second one is from Will Rogers he said about pilots, but he said that being a good pilot, doctor, teacher, whatever, being a good pilot requires good judgment. Good judgment comes from experience. Experience comes from bad judgment. So I think those are kind of the rules of my life, and I think sort of frame my career. All right, so I'm gonna now share my screen. Share screen. Share. And I'm going to go to. Everybody see the screen? It's showing up. Is my screen showing up? Anybody? All right. I'll assume it is.
Yes, we can, Andy, it's showing. Yep.
All right, I'm going to put I'm going to put this in mode. There you go. All right.
Perfect.
So, all right. So what you need to know about sleep, and I must say that the things that you're going to learn tonight, you're going to say, "Oh, I wish I knew this when I was younger." So it may be too late. Some of these things may be too late for us, but it's not too late for our family, our kids, grandkids, and friends. All right. So the goals of my talk really are. My strategy is to try to educate you folks on these issues. Why we need sleep. I'm going to talk a little bit about what we call the two-process model of sleep. A little bit of physiology. I won't get too deep in the weeds, but I think it's important to understand this. And then I'm going to talk about fatigue, because fatigue is a very common complaint. Most doctors estimate that 90% or more of their patients coming to the office complain about being tired. But fatigue comes in 3 flavors, and they're not mutually exclusive. We'll talk about that. And then I'm going to talk about the consequences of inadequate or poor sleep, and learn what I learned all those years ago that I didn't know. And then we'll talk. Then at the end, I'm going to talk about some of these sleep disorders, but it's just going to be a brief mention them, and I'm going to leave details to maybe the period when we have a question period. I'm also going to have my rules. These are the things that I think people should do or should do and behave. If I were king of the universe, I would make some of these changes. Some of them require government intervention. Okay, so why and how we sleep. So the first thing is glymphatics. Now, glymphatics is something that's in the brain that serves the same function as the lymphatics in the rest of our body, but the brain is unique and much more complicated. And these glymphatics we didn't learn about in medical school, and they were only discovered about 20 years ago. So the brain doesn't have normal lymphatics, but they have these things which were named glymphatics, which is a play on words because glial cells are the supporting cells of the brain, and lymphatics are lymphatics. So somebody made a clever new word. The two-process model of sleep and sleep stages. So this is the first part is going to be some science, so you'll have to bear with me. I'm not going to try to train you to be sleep doctors or neurologists, but we want to go through. So I'm not going to go over all these little places in the brain, but I just want to say, and I don't know if there are any other doctors in the audience tonight. I know Ed Wing was hopefully going to start up, but I just want to point out that sleep is of the brain, meaning that the brain controls our sleep. It organizes our sleep. It starts it and stops it and shifts the sleep stage and so forth. But sleep is for the brain. And when I was in medical school, we kind of learned what a lot of these structures were, but we didn't know what they did. But just here, roughly, you're looking at the cortex, the cerebral cortex. Then underneath that, you have the thalamus and the hypothalamus. And the hypothalamus is kind of where a lot of action occurs for the control of our body. It's kind of air traffic control for the body. Here you have the cerebellum, and this part here is part of the pons, which wraps around here. So it's very complicated. And I just wanted you to know that these things have been worked out only recently. And so none of us learned this. We knew nothing about sleep in medical school, except that we weren't getting any once we got into the hospitals. So the lymphatics, again, I'm not going to go into details, but this is kind of a schematic of kind of slice of brain, as it were. So you have the artery going into the brain. You have the vein coming out of the brain. You have these things are the neurons. So these are the nerve cells with these long extensions, which ultimately will wrap up into nerves. And these other things look like octopi are really support structures. These are glial cells, specifically astrocytes, and these are support. And here, right around the artery, at the periphery of the artery, it's a channel, and that turns out to be the place that the cerebral spinal fluid kind of gets into the brain and then percolates through the tissue and mixes with the brain tissue itself. We call that interstitial fluid. So you have to understand that the blood doesn't do the body any good if part of the components of the blood doesn't get out into the tissue itself. And that's what the purpose of lymphatics are in all the other tissues of our body. The lymphatics are kind of like a sump pump. It's like when you have a leaky plumbing and you get flood in your cellar, you have a pump that pumps the water back out of your cellar. Well, that's what the lymphatics do. They pump this fluid that's in the tissue, it collects it and pumps it up, and ultimately is collected and joins to the veins, and it joins to circulation. If we didn't have lymphatics, our tissues would swell, and they often do, and that's because either the lymphatics are injured, defective, blocked, or we're just producing so much fluid because our capillaries are leaking because of disease or inflammation or so forth. But in the brain, nobody had ever seen lymphatic structures. And so until they realized that these channels which run outside the artery, that brings CSF in, and then the interstitial fluid and the CSF leave and get back into the circulation by channels around the vein. So that's the basic idea. Now, this green stuff is the fluid in the interstitium of the tissue fluid, and these little dots, those represent things, chemicals, substances, and so forth. And these are specifically refer to beta amyloid. So many of you have heard of beta amyloid. That's the stuff that accumulates in your brain when you have Alzheimer's disease. So there are other proteins, substances, tau, and so forth. And these are the things that we want to be cleared from our brain. Now, the trick is, unlike the rest of our tissue, the brain these channels only open up when we're asleep. The brain is so tightly packed, it's so tightly packed inside the cranium when we're awake that there's no room. These channels are just compressed and collapsed. That's why they probably weren't seen for a while. They open up during deep sleep, and deep sleep occurs mostly in the first half of our night. So when you don't get deep sleep or you sleep deprive yourself, you are not clearing the evil humors that are accumulating in your brain. So I think that we didn't know that. So when people used to ask me, why do we sleep? I would very glibly say, so we're not sleepy. That was kind of a glib answer, but actually now we know that sleep is very important for the maintenance of the brain's function. And so you just because you can, human beings are the only animals who restrict their sleep willfully. So just because we can restrict our sleep does not mean it's a good idea. And that's something that I learned too late. All right, the two-process model of sleep. So this is, we have two balanced processes. The process S means the sleep drive. So sleep drive is like thirst, hunger. If you don't sleep, you get sleepy. But unlike eating, we don't sleep during the day, off and on during the day, like we did when we were babies, and and as we get older, we try to stay awake the whole day. But the longer you're awake and the more exercise you do, the more physical activity, the stronger the sleep drive is. This is the thing that's trying to put you to sleep. It's actually associated with a chemical that accumulates in the nervous system called adenosine. You don't have to remember adenosine, but what you do have to remember is that caffeine is a direct antagonist of adenosine. So when we drink those energy drinks, we are trying to fool Mother Nature and compensate and stay awake, even though our body is trying to tell us that we need sleep. But the thing that allows us to stay awake during the day as we get sleep deprived, as the day progresses and we haven't taken a nap and we aren't falling asleep, is the circadian mechanism, the circadian rhythm. This is the internal clock, and it's located in a part of the brain which we call the SCN, because its full name is the suprachiasmatic nucleus. You don't have to remember that, but there really is a location where this timekeeper is there. It actually controls a lot of other minor clocks in the other organs and so forth, but this is the master clock. Now, this clock is influenced by light and darkness. In fact, light sets the clock. So when we get up in the morning, if there are certain receptors in our retina that have nothing to do with vision, this activates, these are called melanopsin receptors. This sets the clock. So when you get up in the morning is what sets the clock. That sets your wake up time if you keep it consistent. As the day and light gets weaker, through a very circuitous pathway, the pineal gland is actually encouraged to secrete melatonin. So melatonin and light really influence and control our internal clock and a lot of processes. But the problem is that human beings, again, we're the only species that has both. We have morning larks and night owls. Most species are either night owls or morning larks. In humans, we think that the reason that the night owl trait, it's not a good trait, actually. It's kind of creates problems, and most of my patients with sleep problems are night owls, actually. But so it's not a good trait, but we think that the reason that the genes that determine this were there because when we started living outside of caves and not in trees, and it was useful to the tribe for night owls to be the night watchman. So we think that's why it persists. But basically, if you're a morning lark, your life is actually easier because your clock is like an Apple Watch. It runs at 24 hours, and you actually don't need light to set it. You will if you're traveling and going to a new time zone. But morning larks, you'll get up. I'm a morning lark. Carolyn's a morning lark. We get up early. It's in the dark, but we get up without setting an alarm clock. Night owls have a cheap wind-up watch installed in their brain. And if you remember what those watches were like, they never kept good time, and you had to reset them every morning. If you didn't, you were going to be in trouble. So that's actually what night owls have to do. Night owls, once they realize somebody tells them you're a night owl, they know it, but they don't realize that it's causing them problems. We tell them you have to get up the same time every morning and make sure you see sunlight or some equivalent bright light. So anyway, the idea of the circadian rhythm, it tries to keep you awake. So while your sleep drive is putting you to sleep, your circadian rhythm is actually trying to keep you awake. And I'll show this on the next slide, and I promise this is the end of the physiology, almost. So here is 7 a.m. and here's 11 p.m. So this is an ideal schedule, average schedule, 7 a.m. morning, bedtime, 11 p.m. So as the day goes on, your sleep drive increases because you've been awake a long time, all right? Your circadian alerting mechanism, it actually parallels your core body temperature, interestingly. So you can think of your core body temperature going up. It goes up, goes up, goes up, it goes up, and then at about 10:30, it peaks. Excuse me, 9:30, it peaks. So at 9:30, it's done, trying to keep you awake. So an hour and a half before 11, your internal clock is going on all cylinders to try to keep you awake. Even if you were sleeping down here, At 9:30, a lot of people notice all of a sudden they feel more energetic. They call it the second wind. But then the clock starts to pull back. And meanwhile, you're still awake for another hour and a half. So your sleep drive is increased while your internal clock is pulling back and not trying to keep you awake. And that's when you fall asleep at 11 o'clock. Once you fall asleep, you're satiating your sleep drive, your sleep deficit, you're repleting your sleep, and your internal clock is getting weaker and weaker in terms of its alerting influence. So it's getting out of the way, so it's not waking you up. And about 5:30 in the morning, it hits its nadir. It's at its bottom. So that's why a lot of insomniacs will say they can't fall asleep until 5:30 in the morning. It's because there's nothing opposing them, and they finally built up enough of the sleep drive. But you can see the importance is that we really need to have our life schedule, when we go to work, where we do this and that, has to be synchronized with our internal clock. And if you're a night owl and you stay up late on weekends, or you're an adolescent and you sleep late on weekends, and you stay up late on weekends, and then you try to go to sleep early to make school, it ain't going to work. You're out of alignment. So the circadian misalignment is a huge problem. And, with people, have long commutes, they're commuting in the morning. And it's one of the reasons why we have kids. In California, we finally passed a law to start school later. So kids should not get up in the dark. They need the sunlight to get their clock set, and teenagers especially should be not getting up in the dark, and they should not be let to sleep late on weekends. But we'll talk about that later. All right. So that's the way the two process works: the sleep drive versus the internal clock. Now, these are sleep stages. I wasn't going to go into a lot of this, but so many of these consumer wearables are always talking about sleep stages and telling you how much time you spend in deep sleep. That would be here. How much time you spent in REM. That would be here. Red for REM, and so forth. And how much time you're awake. They really can't do that. These wearables can't do that, and except for one wearable that makes that's not a consumer wearable. It's a medical device. So I don't know how they do it. They don't tell us how they're doing it. So these wearables are good for telling you pretty much if you're moving around or not moving around, and if your oxygen's dropping at night, which is useful information, but it can't give you sleep stages. So in the beginning, when you fall asleep, this is an actual. We call this a hypnogram, like a histogram of the distribution of sleep stages over the night. Appears wake. You see the patient kind of falls asleep, but doesn't get in consolidated sleep until they hit there. And this is transitional sleep. They go to stage 2 or into. They go down to deep sleep. This is the deep sleep. This occurs mostly in the first third half of the night, and this is when those lymphatics are opened up and can drain the brain. About 90 minutes, 75 to 90 minutes after sleep onset, you'll have your first REM period. REM is not deep sleep. Everybody thinks REM, that's when we dream, but it's not deep. You may or may not have realized that if you're dreaming and the phone rings, as mine did last night. I've gone years and not gotten calls because I haven't been on call, but I got 2 calls from the sleep lab last night because for some questions. So, but I'm not falling asleep.
Andy, remind us what REM stands for, please.
REM stands for rapid eye movement. So when the way we stage REM sleep is the brain waves look like you're awake, because in a sense you're living in a fantasy world. You're doing things, and so your brain waves look like you're awake. They're hard to distinguish, but your eyes are flicking back and forth. And if you had a pet, a dog, if you have a dog and they stream, you know it because they're whimpering, their feet are kind of twitching because they're trying to run, but they can't run because part of REM sleep is the body paralyzes your muscles. So REM sleep is so interesting. In kids, we call it infants, they call it paradoxical sleep. So the brain's active, but the body is quiet because the brain is actively inhibiting the lower motor neurons. So that's why sometimes dreams are associated with frustrating things. You feel like you can't accomplish something. You can't run as fast as you're trying to escape something you can't run. You're trying to, and the dog is trying to run too, but he can't. Always twitching, and that's one of the reasons he's whimpering, because he can't get the cat. So REM is very light. So when you get awakened from REM, you will transition to alertness right away. Your speech won't be slurred. The doctor who gets awakened in REM sleep will be able to talk to the nurse and make something sensible. Whereas if you wake the doctor up in deep sleep, he'll sound drunk, right? And then we spend half the night in this intermediate stage called stage 2 sleep. So we have 3/4 of our night we're in non-REM sleep, and 1/4 we're in REM sleep or dream sleep. So we basically, this is simplistic, but we think that the deep sleep is when the metabolism of the brain slows down and the brain literally shrinks. The volume of the brain is less, and that's what allows those lymphatics to open up. REM sleep is particularly important in the immature brain up to the age of 22, 25, because this is kind of associated with setting down new pathways. And then stage 2, we think, is kind of the editing part of sleep, where we kind of clip off and eliminate some of the pathways that we no longer use, like we no longer need to know how to suckle, although maybe we do. So anyway, so that's what we think. So this is deep sleep, intermediate REM sleep, and then here's a period of wakefulness. It's very typical for adults to wake up during the night for a short period of time. That's not abnormal. What's abnormal is not being able to go back to sleep. This person was in the sleep lab, so you can understand why they were awake a little longer. But this is otherwise a normal organization of sleep. All right, let's talk about tiredness. So tiredness, the rest is going to go fast, but tiredness is what people complain about, but they're really talking about different things. So they describe it by being exhausted, tired, low energy, not motivated, brain fog. So 3 types. Sleepiness is a specific form of tiredness. Now, these are not mutually exclusive. So if a person is sleepy, that means that if they lay down in the afternoon to take a nap, they will fall asleep. And sometimes they will not lay down and they'll fall asleep in the middle of doing something like watching TV or reading a book. All right. So that's sleepiness. If that's to a point where it gets in the way of their life, that's pathologic, and that's a sleep disorder. Right. Sleepiness means sleep disorder, period. There are other sleep disorders that aren't associated with sleepiness, but if you are sleepy, you have a sleep disorder, period. Need to be evaluated. Cardiopulmonary metabolic impairment, meaning exercise intolerance. So some say they're fatigued or tired because they can't walk up a hill, or they can't ride, and so forth. And so that's either due to the heart or lung function. It can be due to metabolic, meaning something wrong with your mitochondria, or it could be something as simple as being anemic. So that's a pretty simple one. The patient will tell you, but you have to ask. You have to ask, and doctors don't. They don't make these distinctions. And then finally, everything else. It's the psychophysiologic fatigue. And this is really depression, chronic insomnia, fibromyalgia, chronic fatigue syndrome, which is now thought to be maybe an encephalitis. And so these are people who they're tired, they don't want to do things, they're not motivated, they're not very functional, and they may complain, especially if they have a mood disorder, of this thing called anhedonia. Now, anhedonia, I want to define this word because not everybody has heard it. I never learned this when I was an English major, and I didn't even learn it in medical school. Maybe the psychiatry rotation, they talked about it, but I didn't pay attention. Anyway, anhedonia. So what does it mean? Well, everybody knows what a hedonist is. A hedonist is somebody who lives for pleasure. Anhedonia is the opposite. Somebody with anhedonia has lost pleasure. Things that they used to like to do, they no longer want to do. And not just because they're tired, it's because they just derive no pleasure from it. So it's a word that carries a big meaning, a lot of symptoms in one word. It's really a nugget of a word. And so when I have somebody that, after talking to them, I say they have anhedonia, I know they're depressed. It's really simple. Okay. Starbucks is not an antidepressant. How did this come about? This observation? Well, I had a patient who had sleep apnea and he had depression. Both are being treated. I was treating the sleep apnea. The psychiatrist was treating the depression, but nothing was working. He wasn't particularly heavy, and he said he thought he was depressed. And I kept asking him if he was sleepy by every trick I know, and he denied it. He said he's not sleepy, he's depressed. Anyway, but then he said an offhand comment. He was a pharmaceutical rep, and he said on his trip down the 101, he said he knew every Starbucks. He knew where every Starbucks was and helped him. And I said, oh my God, I said, Starbucks is not an antidepressant. So I put him in the lab and he fell asleep on our nap studies. This is the way we quantify sleepiness. And he was asleep in 1 minute, 1 to 2 minutes in every nap. So he was asleep. He didn't have narcolepsy. He had a kissing cousin disease, which is a kissing cousin of narcolepsy. And he was really sleepy, but he never thought he was sleepy. So what I wish primary care doctors would do, they would adopt this Epworth sleepiness scale. It's a questionnaire. I'm not going to go over the details, but if you look at these questions, what's the likelihood you might fall asleep in these settings, sitting and reading? Not talking at bedtime. I'm talking about during the day or evening, watching TV, sitting in a meeting or classroom. So if any of you, I can't see any of you nodding off, you're sleepy. Sitting or riding in a car or bus for half an hour, meaning a passenger in a car, mainly because if you ask somebody if they fall asleep driving, they'll never admit it. I admitted it, all right? Lying down to rest or nap in the afternoon. This one, if you're sleepy, you will, and you lay down, you should fall asleep. Sitting and talking to someone. Most people have not done that. Sitting quietly by yourself after lunch. There's a reason for I'll talk to you. If somebody reminds me, somebody make a note, remind me to explain what food coma is about. All right. Okay. So I don't want to talk about it right now. And sitting in a car stopped at a stoplight. So I will tell you, I have fallen asleep in every one of these situations when I was sleep deprived, including sitting and talking to someone. I was interviewing a patient, and he was elderly, although he's probably younger than I am now, but I thought he was elderly, and he was a little slow in responding to the questions. The next thing I know, I dozed off, and I was sitting there, and they were looking at me like, "You okay?" So all right, so after lunch, I was all those we used to have noon meetings at the hospitals and noon conferences, and in those days as an ICU doctor, I was always falling asleep. All right, so if your fatigue is sleepiness, you are dealing with the sleep disorder. Now what is a sleep disorder? Okay, from Garfield, you got to take me to the vet, John. I'm having trouble sleeping. It seems like I just get into bed and then boom, 12 or 13 hours later, I'm wide awake. Well, we know he doesn't have a sleep disorder. He's a cat. That's normal sleep for a cat. So, however, if you're a human being and you sleep 10 hours, but wake up feeling good and you're not sleeping, you technically have a sleep disorder called long sleep, but that's not going to be a problem. It's just inconvenient. And there are some people that need 9, 10, and 11 hours. If you get to 11 hours, then we do consider a sleep hour. But the thing is that if somebody gets 11 hours and they still feel fine and they feel fine the rest of the day, it's hard to call it a sleep disorder, but they're not going to be able to get that much sleep. So causes of sleepiness are obviously sleep deprivation and some medications which are sedating. And then we talked about the circadian misalignment. So a teenager that goes to sleep at 3 a.m. and sleeps till 12 noon on weekends, he's going to have insomnia when he tries to go to sleep at 11 p.m. and he's going to have daytime sleepiness when he has to get up at 7 a.m. for sleep. Sleep apnea is certainly the most common thing. And then a condition called periodic limb movement, where your legs twitch and can disrupt your sleep. And then we have narcolepsy and primary hypersomnia. This is a disorder of the way the brain, controls and organizes sleep. So, and these are real diseases. And, it's amazing when you know how complicated the brain is. It's amazing that it works as well as it does most of the time. But we think that each of these diseases probably mostly gets missed. Average 17 years delay in making a diagnosis average, but nevertheless, the prevalence of narcolepsy and idiopathic hypersomnia in the general population is probably the same as multiple sclerosis, but multiple sclerosis usually gets diagnosed and narcolepsy doesn't. Okay, what's the consequences of sleepiness? Well, it affects your brain, function, cognitive. It's unsafe, causes increase your risk of cardiovascular disease, heart attacks, and strokes. It makes you get fat, and it actually makes you more prone to infections. So this is a good example of one consequence. If you're a deer hunter and you fall asleep, the deer will eat your lunch. Okay. A prayer. When my time comes, I want to die peacefully in my sleep, like my grandfather, unlike the passengers in his car who died screaming in terror. So, all right. Seriously, 20% of drivers admit to falling asleep at the wheel. These accidents, this is from our 101. These accidents usually occur about 4 a.m. in the morning. They are single. The truck driver falls asleep. He never puts on his brakes. He just dozes off and goes off the road. And the 101 that day is stuck. These are because remember the internal clock is it's not keeping you awake at 3 or 4 o'clock in the morning. This is a Greyhound bus, so I guess we should not leave the driving to us or them. Air controller falls asleep. The jet lands without tower's help as a pilot. That's kind of interesting. Actually, subsequent to this, there were 2 pilots in an airline were busted when they overflew their waypoint on their way to their destination, and because they were both asleep in the cabin. Sleep deprivation and cognition. This is shows that they did neuropsych testing on adults and showed that the sleep deprived individuals did worse on their cognitive tests. Kids, attention deficit ADHD in kids shows that young kids test out as ADHD. So years ago, 30 years ago, I started making the point that I thought that some of these kids diagnosed with ADHD may have sleep apnea because we weren't taking out tonsils routinely. And the psychiatrist who ran the ADHD practice in Santa Barbara blew me off. But 5 years later, that was I was right. I didn't publish it, but at least 35% of kids with ADHD did have sleep apnea, and I think that that percentages of ADHD caused by a sleep disorder is more and more. The percentage is going up. So for you educators, this is a big deal. I think that it's being missed because the psychologists don't communicate with the sleep doctors, and vice versa, I guess. Sleep deprivation, it increases your blood pressure. That your blood vessels lose their elasticity due to the mechanism is due to something called endothelial dysfunction. You don't have to know that, but basically, sleep deprivation is a stress on the body. So not only is sleep apnea a stress on the body, but so is sleep deprivation and increase your risk of high blood pressure. And sleep apnea, we know, is associated with increased risk of heart attacks and fat. This is a twin study showed they were able to show with twins that the ones that got less sleep got fatter. Okay, so we're just about finished, and I'm not doing too bad. So sleep apnea, that's the most common sleep disorder, and unfortunately, it's a key disease. I know that a lot of our classmates have been diagnosed and are treated for it, but sleep apnea is not the only sleep disorder, but unfortunately, a lot of my colleagues in the sleep field have become sleep apnea doctors, and they really don't know, but they don't want to deal with any of these others. So insomnia is the most common sleep complaint in the country. When they do the big surveys, that always top of the list. 2/3 of the population complain of insomnia. Hypersomnia, and this does not make you sleepy, interestingly, is as little sleep as the insomniacs get at night, they can't nap during the day. So if somebody has insomnia and they're sleepy, they have 2 different sleep disorders. Hypersomnia is what we just talked about, narcolepsy, idiopathic. This is not lack of discipline. This is a neurological disease. Circadian rhythm disorders we talked about. Restless legs is something that causes a discomfort sensation in your lower extremities as the evening or bedtime comes. So it's a cause of insomnia. It's a neurological disease. The problem is in the central nervous system. We know where it is. It's relates to lack of proper function of dopamine in that part of the brain. And then periodic limb movements is when these folks go to sleep, their legs are twitching. Some people can have legs twitch at night and not have this. So this causes insomnia. This causes sleepiness. And then finally the parasomnias. That's the sleepwalking, doing inappropriate things when you're sleeping. So kids sleepwalk when they're sleep deprived. They have a rebound in deep sleep, and then if something disturbs their sleep, they get up and have a partial awakening. So they're like the zombie. They're walking around. They don't remember it. There are parasomnias that occur out of REM sleep, so people do act out their dreams. Remember, you're supposed to be paralyzed. You're supposed to be paralyzed when you dream, but sometimes, like all systems in our body, sometimes that breaks down. So the people, in fact, they're not paralyzed and they're able to act out their dreams, which becomes dangerous. So they can injure their bed partners, they can injure themselves, and worst of all, if any of you have this, I'm sorry to tell you this, but it needs to be evaluated because it can precede the onset of neurodegenerative diseases like Parkinson's, most commonly, by 10 or 15 years. So if you just started having this now, but otherwise you're fine, you're okay. If we call it REM behavior disorder. If you have it now, you probably will not live long enough to manifest Parkinson's disease. But when this shows up in a 50 or a 55-year-old, then it's really a problem. And I've been in practice long enough to see people and see their Parkinson's show up 20 years later. So that is pretty much this. Except I'll just go over my Binder's rules, which should be obvious for most of them. I don't believe students should wake up in the dark. Daylight savings time should be abolished. It's a crime against nature. We're working with California legislators to try to do that. Adolescents should not be allowed to sleep late on weekends. It's now known to be an independent risk factor for suicide. Adolescents that are allowed to sleep late on weekends, independent of mood disorder. Caffeine is not an antidepressant. If your fatigue or tiredness is sleepiness, you have a sleep disorder. If an individual is taking a stimulant for ADD or ADHD, they need to be evaluated for a possible sleep disorder, because if you fix that, you may fix their problem so they won't need amphetamines. If an individual is being treated for a mood disorder and they are also sleepy, they probably have two diseases. They have a mood disorder and a sleep disorder. The depression does not cause sleepiness. The sleepy brain will be cognitively impaired. The sleepy preteen will be irritable and squirmy. That's a 13-year-old. And you get up by the clock and go to bed when you are sleepy. That's one other point I meant to mention is that that two-process system which works perfectly in 9-year-olds. So 9-year-olds are the perfect sleepers. If they're not perfect sleepers, there's something wrong. And it also means that you don't want to sleep like a baby. You want to sleep like a 9-year-old. And I think that's my summary here is specific cause. Sleep is one specific cause of fatigue. It always has a cause, and it's almost always treatable. It has to be treated, really, because it's dangerous not to treat it. Sleepiness is important consequences in terms of safety, performance, and long-term health. Sleep disorders are unfortunately still underrecognized, misdiagnosed, and undertreated or incorrectly treated. And if you have a sleep problem, go to a sleep doctor, not a sleep apnea doctor. So that's my talk, and there's time for questions.
Great. Andy, thank you so much. And you're going to stop sharing your screen, right?
Right. Stop share.
There we go.
Yeah, I'm trainable. All right.
Okay, and here we are back at gallery view. We've got 40 people on. That's wonderful. Thank you so much.
Wow.
So let's do the questions. You guys know the drill by now, right? Down the bottom of the screen, there's something called reactions, and you can raise your hand electronically, and we'll see it, or you can do it the old-fashioned way, and I or Larry Ricketts will do it. I have some questions, but I think let's see what you guys have. So
Let me interrupt for a minute, Alan. We've got a number of people that their screen is not on. Put your screen on so we can see you and you raise your hand or wave your hand.
right. Art Lutzke, Peter Krause, John Roberts, Don Steinmiller, Tom Phillips, Malcolm Getz, Barry Grabman. We'd love to see you. Okay.
I want to see you, Jack. We were roommates. Yeah.
Okay. Jack Hunt. Please unmute yourself first. Jack, you need to unmute, please.
What is wrong with you if you can't sleep unless you read for 1 or 2 hours at night?
Yeah,
Say
okay.
it again, please.
Yeah, I'll repeat the question. He wants to know what's wrong with you if you can't fall asleep without reading for a couple of hours. Did I say it right, Jack?
Yes.
Okay. Yeah. So in adults, in grown-ups, sleep onset insomnia is almost always due to that circadian misalignment. Now, I actually advocate for reading before bed because we call that stimulus control. It kind of diverts your attention away from your life's problems and your unfinished chores. Your to-do list that's unfinished and so forth. So so the trick is that often people, because they're having trouble going to sleep, they try to go to sleep earlier. All right. So, Jack, let me ask you, what time do you get up in the morning? Jack?
I would say between 7 and 8 a.m.
Okay, 7 8. And what time are you getting in bed?
Between 10 and 11.
Yeah, so that's too early. I mean, 11's borderline, but we'll split the difference. If 7:30, if 7:30 is your wake up time and you see sunlight, you make sure you have good sunlight exposure, your brain does not want to let you go to sleep until 11:30 or midnight. So I think the trick is there. And once you go to sleep, do you stay asleep?
Pretty much, yeah.
Well, you're better. So the trick is for you, I recommend you just keep yourself awake a little longer, read a little longer. Well, you're already doing that, but I'd say don't even think about going to bed before midnight, for instance. And so I like people to get up by the clock, but go to sleep when they're feeling sleepy. So a lot of times we say you should do your reading and relaxing outside of your bedroom, and then don't go into your bedroom till you're feeling sleepy. So you get in your bedroom and you fall asleep pretty quickly. Whereas if you have frustration about not being able to fall asleep, that just is a self-fulfilling prophecy. You start getting anxiety about, say, oh God, I sure hope I can fall asleep tonight. And then of course that becomes self-fulfilling. So I think if you stay asleep pretty well during the night, I think you're doing better than most adults. Most of us are getting up during the night, and some have trouble going back to sleep.
Okay, Ron Bones.
Do you have any of that restless legs? Do you have any physical discomfort when you're reading?
Andy, let's go on to another question. Okay.
Okay.
Yeah.
Did you call on me?
Yeah.
So about 20 years ago, I had a really weird experience. A senior partner in my law firm asked me to go to dinner, and it turned out he had the niece show up too, who I didn't know, but she was like 20 or 30 years younger. And somehow we were at a bar, then they drove to the restaurant and I drove the niece to the restaurant, and we had a good time. We talked about where she lived and what was going on. And then we all left, and I drove her back to her car. When I got to the car, and she was in my car, she was sound asleep. And I tried to wake her up and all, but I couldn't. And her car was right next to mine. So because we talked about where she lived, I drove to her house. She was able to get out of the car, walk into the house, walk upstairs, flop into bed, and then I left. And I was just dumbfounded. And about 3 days later, her boyfriend called screaming at me that I was with her girlfriend at midnight at her house. And I described what happened. And he said, oh, she has narcolepsy. What the hell?
Yeah. So
Does that sound right?
Yeah, no, it does. So narcolepsy, narcolepsy happens to run in my family. All right.
Oh, okay.
And I actually give lectures on. I give lectures. I was on the advisory committees on some of the companies that make medicines for narcolepsy. So narcolepsy it's you're missing. Actually, this is a good segue. There's type 1 and type 2 narcolepsy. So take type 1 narcolepsy, is classic narcolepsy. It's not only associated with being able to have sleep attacks, fall asleep anytime, but it's also associated with paralysis. That suddenly a narcoleptic, if they have type 1, if they get emotional, their muscles will go weak. Well, actually, and they can fall to the ground. You've seen, probably some of you have seen these, goats and that have been bred to be narcoleptic. So, and that's called cataplexy, and they're not falling asleep. Their muscles won't support them. So that's part of this REM related paralysis I was talking about. So narcolepsy is a disorder where the boundaries between sleep, wake, and REM are blurred and unstable. So REM sleep can intrude on wakefulness. So they'll have hallucinations, or they'll have paralysis, or they'll have a cataplexy attack. That's, in other words, all manifesting some aspect of REM sleep, and then, or just the false sleep, or when actually at night, the narcoleptics will often wake up because wakefulness will intrude on sleep. So the organization of the sleep stages is not proper and not stable, and it's because of a missing peptide called hypocretin. But I want to mention hypocretin but we were talking about food coma. Well, hypocretin exists in those of us that don't have narcolepsy, and hypocretin it stabilizes the sleep boundaries, the sleep-wake REM boundaries, but also when we're hungry, the brain secretes it and makes you awake. It wakes you up if you're hungry. And therefore, if you get sleepy after you eat, it's not because the food made you sleepy. The food satiated your hunger, and you no longer have the benefit of this hypocretin, which waking you up. So if you fall asleep after food, it's unmasking your underlying sleepiness. So if you're an animal, if you were an animal that was hungry, it would be maladaptive not to get sleepy when you need to be hunting. So that's what basic. So narcolepsy is a total neurologic disease where sleep intrudes on wakefulness. Usually, though, I will say it's a little unusual. Jack? It's a little unusual. I mean, it was that they were so hard to wake up, because usually narcoleptics can wake up pretty easily. So she may have had the other disease called idiopathic hypersomnia.
But she couldn't drive, but I could wake her up to walk into the house and walk.
Yeah.
But that was about it. I mean, it was like sleepwalking.
Well, we have that when people are in deep sleep. So they have. When people have deep sleep, it's hard to wake them up anyway. They have what's called sleep inertia. So that may be in the problem, but it's an issue. You have to know more. But narcolepsy is sometimes used. Sometimes
Andy, let's go on to some other stuff. Okay.
Sorry.
Larry Ricketts. Larry, would you unmute?
I've got a quick question that I'm sure everybody asked. It is, with all the over-the-counter sleeping medicines and the prescribed sleeping medicines like Ambien, what's your advice on Tylenol PM all the way to Ambien if somebody has insomnia?
Yeah. I'm really glad you asked this question. I figured somebody would. First of all, Tylenol PM, the PM part is Benadryl, diphenhydramine. It's a first generation antihistamine. It's a terrible drug. I would say I think it should not be. I think this is one of those things that should not be available over the counter, because it's everybody thinks it's safe. It's long acting and it causes withdrawal. So it actually exacerbates things like restless legs. So you should absolutely stay away from all those antihistamine related sleep aids. Ambien for chronic insomnia. The drugs like Ambien and the new hypnotics, new generation of hypnotics, almost never will work for chronic insomnia unless you make an effort to identify and change some of the habits we call maladaptive habits. For short term, somebody's in a crisis, stressed, and so forth, and they can't sleep, then I'd say Ambien and some of the other drugs are fine. The benzodiazepines, the Valiums, and the kissing cousins of Valium and so forth, those drugs we've steered away from them, the benzos, because they're not dangerous, but their withdrawal, it can be dangerous. So used properly. But for chronic insomnia, you have to address the sleep habits and the behaviors and so forth.
So, Don Brown asks, is there anything particularly unique about old guys in this arena? And I'm going to piggyback on that and ask Andy to address two things. One is naps in the afternoon, and the other thing is getting up to pee at night.
Yeah. So as I
I'm
mentioned,
asking for a friend.
yeah, right. Yeah, no. First of all, as I mentioned, when I hear that when I see somebody in our age group or even younger, when I hear that they go to sleep and they sleep through the night and they um, wake up feeling refreshed, I'm amazed. That would be abnormal and good for them. Most people who of our ilk, we will wake up during the night. To urinate, some pain, so forth. And that's not abnormal. It turns out the first part of the night, we have that deep sleep. And so it's not abnormal to wake up in the middle of the night. What's abnormal is not being able to go back to sleep. And if you have something that's waking you up very frequently, hopefully you can address it. Usually it's, bladder, prostate, sometimes pain and so forth. So you address it, but as long as you go back to sleep pretty quickly, that's okay. We don't sleep as deeply as we get older. We don't sleep as deeply as we get older. It's sometimes associated with, as I said, bladder, prostate, pain, but it can also be medication that we're on. It could be other medications common. For instance, the beta blockers very commonly used. They're not good for sleep. So so we don't have as much deep sleep. This so-called N3 sleep, it decreases. I think although I have seen some healthy older folks that have a fair amount of deep sleep, but so I just think it's part of the aging process is to you'll have interrupted sleep, but the amount of sleep you need is the same as when you were 30 years younger. So if you don't get it, you will be a little sleepy during the daytime, and it's okay to take a short nap in the afternoon if you're sleepy and your schedule, if it's not doesn't affect your life, go ahead and take a short nap. But I would say 20 to 30 minutes is better than 2 hours, because when you sleep for 2 hours, you will screw up your nighttime sleep. You kill that sleep drive, and so I say short naps are okay. And in the European country, the Western Europe, they routinely go to sleep late. They spend less time sleeping nighttime thing, and they take their siesta. If it works for you, it works. Yeah.
Okay, I have a question from John Huffnagel, and then we'll go to Rick Ackerley. Huff asks, what dose of melatonin do you recommend for people when they travel or for shift work?
Yeah. So, okay. So melatonin to shift the sleep-wake cycle, and if you have no other reasons to be on melatonin, and I'll come back to that, then you only need a half a milligram. A half a milligram, but you have to know how to take it. You can't take it at bedtime. You have to take it about 5 hours. You take a low dose of melatonin about 5 hours before your desired sleep time. So, which is what's missing. However, if you're on a beta blocker, you need to take higher doses of melatonin because beta blockers are antagonists they antagonize our endogenous melatonin. So there you can take 2 or 3 milligrams, 5 milligrams. And then for certain diseases, for people with that REM behavior disorder or Parkinson's disease or early Parkinson's disease, we think that it's hard because melatonin's over the counter. We don't have a prescription grade melatonin, so it's a little hard to be sure. But we think melatonin given consistently at a consistent time at night may actually have some neuroprotective benefits. So that's a work in progress, but it's very interesting. And there are 3 melatonin receptors in the brain: MT1, MT2, and MT3. MT1 is a sedating. It causes some sedation. MT2 adjusts your clock, and MT3 we have no idea. We have no idea what it's doing.
Okay,
Right.
Rick Ackley.
Hey, Rick.
Alan was talking about me waking up every night, every hour, and I'm sure he was talking about me. eh, my question is, I mean, I'm concerned from what little I know. You want to get, it's good to have your REM sleep because that's where you dream, and dreaming is good. But you got to have at least 3 hours of non-REM sleep, and I'm not getting it.
No,
How do I get my 3 hours of non-REM sleep?
well, so you actually need to be diagnosed. That's you're way out of the, what we consider the, within the range of normal. That's abnormal. So you actually need to be evaluated, and this is an issue. So you put people in a sleep lab. It's a very, that we consider that our gold standard for evaluating sleep disorders, but it's a very abnormal environment, and it may not, and the sleep lab schedule may not be your schedule. The sleep lab itself can cause, the sleep in the sleep lab can be very typical. We figure that about a third of the patients sleep the same as they do at home, a third in the lab sleep better, the insomnia essentially, and a third sleep worse. So
Yeah,
there's some new
I did go to a sleep lab and it was bad. Yeah, it doesn't work
yeah,
for me. So
yeah. So
how do I get that addressed?
yeah, so there's a new technology out there, and you have to look around. Rick, where are you located? I should know this, but I don't remember. What part of the
Yeah,
country?
probably walking distance. Yeah, so in Tiburon.
Tiburon. Oh, okay. All right. So
San
actually
Francisco.
good. Okay. Tiburon, Tiburon is good because Northern California, the sleep doctors in Northern California uh, have embraced this new technology, which I've embraced. It's called, write it down, sleep image. It's called a sleep image ring, and it's absolutely amazing. It's too long to explain it, but it actually is amazing. And it's unlike most home tests. Most home sleep tests just look for sleep apnea, but the sleep image ring actually looks for, it identifies the stability of sleep, and that's kind of what you need. So Rick, I will have to get you. I need to get you a name of maybe some sleep doctors, in your area that and to see them. Were you, besides going to a sleep lab, did you ever see a sleep doctor? I mean, did you ever have a
Yes, I
consult?
did. I did about 10 years ago, and it was a very bad thing.
Yeah, yeah, yeah.
Sleeping in that machine did not work for me at all.
No, yeah. So what I'm going to do is I will get you. Remind me, email me afterwards, and I have a chance. I'll look up. I have somebody that's in Northern California. I have to figure out the distance, but whatever the distance is, he's actually asleep.
Okay,
Not
okay.
because,
Andy, let's go
yeah.
to Howie Klee and then Don Steinmuller, and then your brother has a question. Howie?
Oh,
Yeah.
Thanks, Alan, for outing me. I appreciate that.
I'm not glad he did.
Question, what happens if you wake up at 3 in the morning and by 5 o'clock you're still awake?
Yeah, yeah.
Should you just give up
What
and
to
get
do?
up, or what do you recommend doing?
So getting up, if you get up and you can't go back to sleep, as I say, usually again, we try to make sure that I'm a bug on this, but you have a consistent schedule. And the first thing you do is go to sleep a little later. Go to sleep, get in bed a little later so you're a little bit more tired. And then at 3 o'clock in the morning, when you wake up, you really should either read something that's not stimulating, or listen to something, a boring podcast or something like that. We call it stimulus control. Try to distract you so you're not thinking, and you're not dwelling on the fact and getting frustrated that you can't go back to sleep. So those are the first things. And that's a very common. That's really the most common complaint. If those things don't work, then there are people, we often work with clinical psychologists, to go over in detail, get a detailed history and find out if there are other issues. But okay.
Hey, thanks. Just a sidebar comment. I'd love to be able to read 1 or 2 hours at night, but unfortunately I fall asleep after about 20 minutes. So
That's right.
a
That's what
long
you want
time
to
to
do.
finish a book.
That's why we use it. That's why we use it as a tool to get people back to sleep. Yeah.
It works great for me.
Okay,
Yeah.
thank you. Don Steinmiller, please unmute.
I see Bob. Yeah. Bob Bear also.
Okay, Don,
Bob.
you got your hand up? Maybe you're not there.
I unmuted now.
Show us
Can
your
you hear
face
me?
if you can, Don.
Don, we can't see your face.
I don't know why it didn't come on.
That's all right.
Is there something I missed on? I didn't see
Okay, ask
why
your
it didn't do it.
Go
By
ahead,
the way,
ask
let me just talk. Can you hear me?
Yes.
Yeah, we hear you.
Okay, so I missed the first half because I was out with the pharmacy trying to straighten out my wife's eye problem. She just had surgery on it. And but the last part I would really appreciate it because I have the same, you have problems with falling asleep like in the car and driving and stoplight. Is that what I took in? That was just when I came into the presentation. Is that
If
correct?
you're so sleepy that you could fall asleep in those situations, then you are sleepy. You have hypersomnia, and that needs to be evaluated.
Okay,
you
I've
need to-
seen three sleep doctors and two sleep doctors, and the third one doesn't want to see me. And it was all sleep apnea. And that I
Yeah,
don't really have
you go.
sleep apnea.
Yeah, so
So-
there you go. That was the point I was trying to make. You saw
So-
sleep apnea doctors. Yeah.
Right.
Okay.
So
Yeah.
the head of the sleep program at Stanford is Dr. Mignot. He
Mignot.
identified narcolepsy, and I thought I tried to see him, but he only sees narcolepsy and its side effects now. He doesn't see anybody else. So I've been very dissatisfied. I've been about a year. I went through all CPAP treatment and help it all. And I don't drive now, which is a big downer on being so
Yeah.
old that you have all these other restrictions and chronic problems. So
Yeah,
are you
there's 8
retired? Are you still working?
No, I'm not retired. Nope, I'm still working.
Okay,
Yeah.
so if
Yeah.
it's okay with you, I'd like to call tomorrow morning, make an appointment with you. And you're in Southern California, is that right?
I'm in Ventura. It's a long way from. Where are you located, John? Where are you?
I'm in right by San Jose, Los Gatos in California.
Okay.
Yeah,
All right,
call,
so,
don't call. I will get it. I'll get it set up. I'm
okay.
a little back
And
on.
Andy, do you have a class of 67 discount?
Yeah, I was going to say, we never thought we'd increase your billings, Andy, when we did this.
Absolutely.
Yeah.
Yeah. I'm on salary, so I could do it for free. But except my boss will.
Don't say that.
No,
All
I'm
right,
just kidding.
your brother
we'll do-
has a question.
Okay, and then
Bob
yeah,
Binder
two
asks-
Bob. Bob
Bob
and
in the other room.
Yeah.
Or Bob, you want to ask it yourself? Are you on? There you are. Bob, you're on mute. You're on mute.
Which Bob?
Bob Binder.
Oh, there he is. Bob, unmute. You're muted, Bob. Unmute.
Class of 63 at Williams. They didn't know anything.
No, yeah. Bob, there's a button. You have to go down to the bottom of the screen.
Okay.
And click.
Can you hear me now?
Yep.
Yes.
Yep.
Okay. Anyhow, congratulations on a great talk, Andy. One quick question. What do you think about all this, the whole thing about not using a computer at night because of the blue light, and does it affect, is there any validity to that?
Absolutely. The blue light it activates the melanopsin receptors in the retina and actually inhibits melatonin. So yeah, so it's like turning a bright light on. It's bright light. That's why you don't want to have bright light, in the evening, because it will interfere with your sleep onset. Yep. Yeah. Good.
That's all I have to ask. Thanks.
Okay, good. All right. How about Bob Bear? I know he's been waving. I mean, Bob and I were classmates in medical school.
Absolutely.
Yeah.
Well, for some reason, my hand I can't find on mine. I know exactly where to look. It's not there. So that's why I was holding it up all this time. I have a question that's somewhat separate. It was much more the case when I was very busy working and had a schedule, where I was staying up late and getting up fairly early. But invariably, whenever I set my alarm, and it still holds true, but I don't set my alarm as often now, I wake up between 2 and 4 minutes before the alarm rings. And I've never understood the physiology behind that. There's clearly a purpose. I don't know whether other people have that as well.
Yeah, I know, and I think that, so I don't know, it is true that, but first of all, you're almost certainly, would you consider yourself a morning lark, Bob? So now that you don't set an alarm, you get up at a consistent time? Or not?
I do, unless Susan keeps me up watching TV or doing something and I'm looking at blue light.
Right, yeah, right, yeah. So, I mean, I think I mean, I've experienced that myself, and I think that when we know we have to get up early for something, I think it activates the brain a little bit, and I think there's a little bit of a sympathetic nervous system increase the activity. So I think it just, since you have your alerting mechanism, you have you're starting, your circadian rhythm is starting to alert you, you've satiated your sleep, and then you just push it a little further forward because you got a little bit of a little boost from the sympathetic nervous system. We're talking autonomic nervous system stuff because he's a doc. So I think that's what it is, but it is uncanny, and I think some people some people do it more than others. So it is interesting. Yeah.
Okay, we're 20 minutes past the hour. I don't see any other hands raised. What we're going to do now is, in a minute or two, we'll stop the recording, and anybody who wants to stay on after recording is stop and just chat. We'll leave the server open, and Andy has graciously agreed to stay on as well. Although he probably shouldn't call this your personal diagnosis time, but anyway. Let's all give a great round. Maybe unmute yourself if you can and give a great round of applause to Andy. Thank you so much.
I hope everybody learned stuff.
That was
Hey,
wonderful.
Bob, Bob Bear, we didn't have any electron sleep in medical school, did we?
Nothing.
Yeah, I just want to make sure. I want to make sure that I want to make sure that I just didn't sleep through that class.
Yeah, not in any subdivision of what we did.
No, it's amazing. I was just saying, before people go, I always say that what I know now is that sleep, exercise, and keeping your weight down are probably the three things that we have some control over. And if we do that, we probably improve our odds of staying healthy. But I did two out of the three pretty well, but the sleep one nailed me. So I think that I blame all my health, whatever health problems I have, I blame it on my lack of sleep in my formative years there. So
Great. Thank you, Andy.
thank you, guys.
I want to give a shout out to Phil Bolton, who's going to be our speaker next month on June 20th. Phil, you're on, right?
Yes, absolutely.
There you are. I have a blurb I could read about you, but since you're sitting right there, why don't you give us a little teaser of what you're going to talk about?
Sure. I was surprised to be asked to talk. I hadn't been really involved with Williams for a long time, and I'm really very pleased to have been. It's taken me to look at as many of the videos that Interlink Media, I guess that's Greg Meister, has made available, and I've enjoyed them enormously, and I've actually gotten other people to watch some of them. Very, very moved by some. Most recently, I saw the Marty Samuels one, and have shown that to several people. Really remarkable video, and there are others there too. It's also made me think about my time at Williams and the relationships I've had there, and I'm grateful for that. What I will do is discuss my career over 50 years as a journalist. As I remember that there have been many cliff moments like Scanlon Gale, where I had to recreate myself and even recreate some of the technology to stay in the field. And as I've reflected on that, I've thought a lot about my time at Williams and how it prepared me for this rocky career. I did want to tell Andy that of all the interviews I've done over 50 years, I had one senior woman, fall asleep on me when I was asking her questions, and I had to lay her out on the couch and leave her living room. I turned all the lights out, and the next morning I called her, and I was pleased to learn that she was still alive. So you just never know when expertise is going to be useful. But look forward to talking with you all, and thank you so much for including me.
Great. Thank you, Phil. We look forward to it. Paul Stryker wrote in the chat about, this is unrelated to the Zoom question. If you have any poli-sci majors, you might be interested in reading the obituary of Kurt Tauber, who died this year at the age of 101. I actually sent that out, Paul, to the class about 3 weeks ago. So this was a test to see if you read the class emails, Paul. So anyway, all right. So we're gonna say good night, but we'll leave the connection open. If you want to hang around, we'll stop the recording. This has been a wonderful evening. We'll see you all on June 20th with Phil Bolton. Thanks again, Andy.
Hey, guys.
Andy, can you hear me?
I can hear you.
Yeah,
Thanks,
okay.
Andy.
I have a quick question. If anybody's been watching the trial of Donald Trump, he seems to be falling asleep. Is that really sleep, or can you tell what's going on?
You know, I haven't been watching it, but you know, he could, because I always heard that I think he's the one that's a short sleeper, so he may be sleep deprived, you know, and so I haven't seen it. I mean, I've heard that, but I know
he also supposedly drinks 10 or 12 Cokes a day.
That's
So
right. So
his caffeine